Thank you very much, Dr. Sipperstein, for that great presentation. So I'd like to open this up for discussion with the panel. And it seems that Dr. Ye and Dr. Sipperstein have a different definition of multi-gland disease. Dr. Sipperstein, you mentioned that you would look at glands after removing the target gland, and if they were enlarged, would remove them. But I'd like your comments on what about the protocol of leaving those glands behind? Because Dr. Ye presented some very interesting data showing in a laboratory that just because a gland is enlarged does not necessarily mean that it is hyperactive. So let's open that up for both of you guys.
Okay, now we're within swinging distance of each other, so maybe our chairs should have been separated, Barry. So to answer the question about how often do you run into a parathyroid adenoma doing a thyroid surgery in a patient who has an absolutely stone-cold normal calcium, and my answer would be that is a very rare event. I mean, if we found that 5% of the time, then we might say, well, this entity of non-functional adenomas may be fairly common. Yes, for the purposes of our study, we defined an abnormal gland as one that is both enlarged and hypercellular, but I cannot tell you there in the operating room, because we remove it, really what its functional status is. We too have done studies in vitro looking at PTH excretion versus calcium level. They are fairly difficult studies to do. They are not incredibly precise, and obviously repeated assays on the same gland can give you varying results. I don't think it's a real clean study.
Dr. Ye?
Yeah, I don't think we fully know the answer to this. You know, the debate is it function or is it morphology? Just by what I said, that may be true of some of the cases and may be true of not. And I don't fault anyone for seeing a gland that looks bad and thinking, oh, geez, I wouldn't want that if it were in my neck. And I think that's reasonable too.
Well, both of you failed to mention that there are some new technologies for localization. For example, 4D CT scanning has become one of the first-line choices of localizing imaging at many institutions. And at our meeting just a few days ago, we heard several new technologies that are permitting intraoperative localization using spectrometry and other novel methodology. So what figures? So CT scanning, how does this play into the armamentarium of bilateral versus focused exploration?
So, I mean, what you really brought out very, very nicely is that the holy grail of parathyroid surgery would be a perfect localizing study. You know, we're left with a gland where the normal gland measures 6 by 3 by 2 millimeters. The last gland to be found in the body really cannot be imaged if it's normal. And so even if a gland is 2 times enlarged, 4 times as enlarged, it's very, very challenging with with some of the promising newer technologies to say, oh yeah, we're going to be picking up 95% of these. So I think that's going to continue to be a challenge in this area in being able to pick up very, very small glands. And again, I agree, there is a discordance between size and function in this area as well.
Dr. Brunt has a question.
I think part of the good news out of this is that with either approach, the outcomes are really quite good. And so I have a question for Dr. Sipperstein, and that is that if you're doing bilateral exploration in everyone, then are you still doing localization studies preoperatively? And if so, how is that changing your approach?
So, because we are doing a study, we are doing both localizing tests in all patients. My colleague, Dr. Berber, has a very interesting study looking at the most cost-effective strategy for doing localization. And the answer to that, to make a long story short, is if you do a neck ultrasound, a cheap, non-invasive, and in our hands an office-based test, and it shows a parathyroid gland, then getting a subsequent sestamibi scan had really changed your operative strategy significantly in a very small percentage of patients. So I would argue that a most cost-effective algorithm would be to use an ultrasound as your localizing study. If it's positive, don't need to get a sestamibi scan.
So go ahead.
But I would just counter that for the ultrasound, it has to be done by someone who is good at reading the ultrasound. It's heavily operator dependent, whether that's the surgeon doing it in the ideal world, or if it's an experienced ultrasonographer. But the reality out in the world is that probably most places don't have the level of ultrasound expertise that allows that to be your initial discriminating
Exactly.
localization test. So.
Right, and you bring up again a very good point, is that the recommendation for the very, very high volume person or center may be different than the recommendation for the person who only does the operation occasionally. And so if somebody is not doing this operation every single day, if they get a preoperative localizing study, shows a parathyroid, may be fine just to take out that one gland and risk a low rate of recurrence, because a reoperation in those patients is not terribly difficult because the other locations have not been violated.
Let's go down and just poll the panel. Just for your index procedure, primary hyperparathyroidism, non-familial, so this is non-MEN cases, do you prefer a focused or a bilateral approach? Dr. Duke.
I would do a focused exploration with very liberal one-sided look and limited bilateral look.
I like that liberal one-sided look. Okay, excellent.
What's a limited bilateral look or the focused
limited
exploration?
one-sided look meaning that, because the surgeons get a sixth sense about things. So there are other factors than just the localization studies or a family history or MEN1 that comes into play. So if I have a clear-cut patient that has very well localized lesion, I would take out that gland. Now, looking at the other gland on the same side actually has minimal effect on either incision size or risk for the parathyroid, etc. So that, for me, that's quite liberal. In fact, for the longest time, Dr. Clark, even though he was getting PTH, he routinely would do that. He was even more liberal than I was. So for him, a focused exploration is actually a unilateral two-gland exploration. Now, bilateral exploration, you can tell how I start. If I make my initial incision on the side, I probably set that threshold pretty high. If I make my incision in the middle initially, it somehow tell me that my evaluation of that patient make me more likely to go to the other side. So that's where that is somehow.
Dr. Linos.
If I do have, from my expert, my guru, specialized in pathology of the thyroid, ultrasonographer, a positive ultrasound, and more often because of the endocrinologist, a positive homolateral system EB, then I would not object to go focusedly, make a lateral small incision, and find the gland. And I would caution that the usually lower gland many times can be the superior gland in a weird place that all of us that do parathyroid surgery should know, because people that are not familiar with this pathology go there and do remove a lymph node or a normal parathyroid and leave that behind the esophagus before the spine, a gland, thanks God, virgin for us to do a second case. So now with the new data that I heard, maybe I should go back to the traditional four-gland disease, because that 16% that Dr. Superstein said made me worry that even if you have both studies positive, then you have a chance of missing a functioning parathyroid adenoma up to 16%.
Dr. Brunt.
But
quickly.
Yes,
Focused, bilateral.
Focused, and just a very, okay.
Dr. Herrera.
My preferred localization study is sestamibi, and when I have a truly positive sestamibi, I do a focal exploration with intraoperative PTH. And since the quick PTH is not as quick in my hospital, in the meantime, I take a look to the homolateral gland.
Dr. Chung.
So I prefer the combination of the ultrasonography and the cystoscopy, and then I prefer the focused parathyroidectomy. So, but in Korea, the multi-glandular parasite disease is extremely rare. So after focused parathyroidectomy, I never experienced of the recurrence. So I want to ask you, all of you, the simple question, the basic question. So in your data, so how many the Asian American population? So I think the definitive level, the racial difference between Western country and the Asian country, the incidence of the primary hyperparathyroidism.
Yeah. So let's maybe have a show of hands from the audience. How many of you who perform parathyroid surgery perform a focused parathyroid operation? And how many routinely perform bilateral expiration? Wow, in a minority. Okay. Two quick questions from the audience. Number one, and this is going to be for Dr. Sipperstein and Ye, one or the other. So how about, Michael, we'll go with you with ectopic glands briefly, because we want to move on. Strategies for finding ectopic glands. And Dr. Sipperstein, if you could comment on the use of methylene blue for intraoperative localization.
Finding ectopic glands, well, definition of ectopic varies. Most of them are going to be accessible through that standard neck incision. If you really think it's going to be ectopic, that's one great reason to get a cystoscopy, because that'll show you whether or not it's in the chest. And beyond that, you may likely fail the initial operation and then you get a CT and reoperate.
Not particularly impressed with methylene blue. I mean, above and beyond, exploring for glands using 3.5 magnifying loops, pretty quickly everything turns blue and looks like a parathyroid.
Okay, I'd like to thank our panelists for their discussion and presentations, and we'll move on to the next and final section. Thank you.